Good morning, everybody. I am very happy to see that many of our participants here in the sessions are not from eSAC, are from different places of the region, and I would like to thank all of you to be here and to start sharing some ideas that in eSAC project we are trying to address in the more deep way. eSAC is an initiative that is shared by the University of Toronto, by the IDRC and the Pan American Health Organization. We have been working for 2 years and a half, and most of our key topics we are working is the way that our region is using ICTs in public health prevention and public health problems control. So we invite you to start thinking a little bit on how these ICTs are contributing to improve public health conditions in our countries. Most of the issues that we have been working during this period, during these 2 years and a half, are already published in our eSAC website, so you can visit it and try to contribute in new ideas. I would like very much to thank especially Mrs. Nancy Muturi and Mrs. Ania Kushine and Marcia Forbes to being here as our presenters. I would like also to ask David from Pan American Health Organization to give us the welcome. Thank you.
Good morning, everyone. Thank you so much, Gladys. And a special welcome from our director, Mr. Marcelo D'Agostino, who is the director of the Department of Knowledge Management, Bioethics and Research. And as already mentioned, Soroja and Gladys, this activity is in the framework of the eSAC project. That is a project developed by the International Development Research Center, the IDRC, the University of Toronto, and us, the Pan American Health Organization. So this is the first activity regarding public health and equity media focus, and we hope that you can enjoy this session and the rest of the day. Thank you so much.
Thank you, David. While we wait on a couple more people to come, I would just like to go ahead and introduce the presenters for today. The first presenter is Ms. Nancy Muturi. Nancy is an associate professor and associate director for graduate studies and research in the A.Q. Miller School of Journalism and Mass Communications at the Kansas State University. Muturi's research focuses on health communication with an emphasis on HIV/AIDS in Africa and the Caribbean, as well as health disparities in the United States. Her work has been published in some of the top journals in her field, and she has written chapters in several health communication books published in the US and the Caribbean. After that presenter, we will have Ms. Ania Kushine. She is a global health practitioner with 8 years of local, regional, and international experience. She has a joint master's degree in international health from the Free University in Amsterdam and the University of Heidelberg in Germany, with a graduate diploma in tropical medicine and hygiene. She has worked with the Ministry of Health in Jamaica, the United Nations Development Program, USAID, USAID, and currently she is the public health specialist at the U.S. Embassy Jamaica with responsibility for the regional portfolio. The last presenter is Dr. Marcia Forbes. Dr. Forbes is a communications specialist and media veteran. She's known in Jamaica for successfully transforming the 40-year-old government-owned Jamaica Broadcasting Corporation into the privately owned Television Jamaica. She's a senior lecturer at the University of the West Indies. Her second book, Streaming, Volume 1, Social Media Mobile Lifestyles, has been released as an ebook, and she was honored for her use of media as a tool to impact both the country and the world, and for her outstanding ability through mass communication and outstanding citizenship. So we have some really, really great presenters this morning and a really interesting topic to look forward to. And I just would like to take the time to thank the presenters for giving up their time this morning and being here to share the experiences in the Caribbean in this area with us. At this time, I would like to go ahead and do the first little polling activity. So we're just going to ask you to use the poll feature, which is right below participants. It is beside there's a smiley face, there is a little person with a timer, there's a hand, and there's an A. The polling feature is the A. So if you scroll over that, you'll be able to respond to the poll by clicking A, B, C, D, or E. And I see that some persons have already answered the poll. I will answer as well. Okay. So if anybody has any issue, you can please go ahead and check the chat. The question is, what region are you from? A, the Caribbean. B, Central America, including Mexico. C, South America. D, North America. And E, other. As much as possible, use the A in the polling section to respond to the question. And the poll is right under participants. It's the little A button. If you hover over it, it gives you the options A, B, C, or D. All right, so I'm just going to show you the responses so far. So we can see that 25% are from the Caribbean in the room now, 18% from Central America, including Mexico, 12% from South America, 6% from North America, and no other. All right, so without further ado, we're just going to go ahead and go into the session and the first presenter. I will hand over to Ms. Muturi for her presentation. Thank you. Ms. Muturi, if you're there, you can just press the top button so that we can go ahead with your presentation. Nancy, I'm not seeing where you're clicking the top button. Could you just try again? Just click again the top button, please. Thank you. Okay. In the meantime, I think while we figure out what the issue is with Ms. Muturi, I think we are going to go ahead and go to the next presentation and try to speak to Dr. Ms. Muturi on the side. So we're going to go ahead with Anya's presentation in the meantime. Thank you.
Hi, good morning. Can you hear me? Okay. So I will be discussing a research study that Sea Change carried out in 2012, looking at the use of social media among sex workers and men who have sex with men in Jamaica. So I'm going to be giving you the rationale for the study, the methodology that we used, which involved software called Gather Data and cell phones, and also the key findings and some conclusions and recommendations that came out of the study. Now, C-Change decided to do this study because there was a need for it in Jamaica, looking at vulnerable populations in particular who tend to not access health information or health centers because they're afraid of being discriminated against. So there was a need to find a more applicable or appropriate way to reach these populations, and social media has been proven to be more effective, especially with populations that tend to hide. Jamaica has a very high internet penetration rate. As you can see from the slide, internet usage is very high at 55%, and that's from the world stats. And according to the Office of Regulation, cell phone penetration in Jamaica is over 100%, which means that most persons have more than one cell phone. Also, in terms of social media, almost over 500,000 Jamaicans are registered Facebook users, the third highest in the Caribbean region. Now, the study, as I said before, aims to explore the use of technology for information seeking and communication among sex workers and MSM, and also to inform the development of communication materials aimed at reaching these distinct groups, and also for broader HIV prevention interventions. So C-Change recruited 15 data collectors from the MSM and sex worker population. They were asked to interview within their social networks or their professional networks, and each data collector was asked to administer up to 80 surveys. Now, the surveys, we started with a paper-based survey, which was then uploaded to a software, a database called Gather Data, and then put on cell phones. We used the Nokia C3 smartphones, and the data collectors actually use the software on the cell phone to answer the questions. So the data was entered directly onto the cell phone and then uploaded to a database. What this allowed, it allowed, I had access to the database, and I could track each data collector. So I could see the number of surveys that each data collector had completed on a daily basis. The database also tagged the time on each survey that was uploaded. So it recorded the start time of the survey and the end time of the survey. And that allowed us to validate the data as well, because we know that each survey would take approximately 20 to 25 minutes to be completed if the data collector had gone through all the questions meticulously. So if I looked at the database and I saw where a survey was completed in 5 minutes, then that was possibly not, that survey would have been thrown out, because it's not possible to complete the survey in 5 minutes if you are going through it the way it is intended for you to collect the data. So we went through that method, and once all surveys were uploaded to the Gather Data software, they were then downloaded into Excel, and we use the Excel version to clean the data and also to run the statistics, mainly frequencies, and also using SPS to look at the population-specific statistics. Right, so as I said, we had 15 data collectors. We looked at 3 urban capitals in Jamaica, Kingston and St. Andrew, St. James, and St. Anne. And we picked these areas because of the high HIV burden in these areas, and also because they tend to be tourist areas. And also ethical approval was received from the Ministry of Health in Jamaica and from MedLab in the United States. Respondents were also asked to verbally consent and then to initial the consent forms, and we offered no remuneration for participation, but the data collectors were given a stipend. So we sampled 448 MSM, 66 male sex workers, and 273 female sex workers through the snowball technique. Most respondents came from the Kingston and St. Andrew area. There was also Northeast Jamaica, Western Jamaica. Southern Jamaica had the smallest respondent, and that may mainly be because the southern areas of Jamaica are not tourist areas, and the population tends to be smaller in that region. So we found that cell phone usage was very high, particularly among MSM and female sex workers. Approximately 92% of respondents reported having a working cell phone, and approximately 69% reported using the internet. MSM were more likely to have a cell phone and to use the internet, while female sex workers reported rarely using the internet. Male sex workers shared similar internet and cell phone use patterns as MSM. Main reasons for using the cell phone. Most use cell phone, MSM use cell phone for text messaging and to send and receive pictures to casual sex partners. Female sex workers use cell phones mainly for text messaging, but their cell phones tend to not have the capability to send pictures, video, or sound, so they were not using smartphones, while most MSM were using smartphones. Most were visiting, the most frequently visited site tended to be Facebook. All respondents reported using the internet, using Facebook, and using YouTube. 95% of sex workers and about 94% of MSM reported using Facebook. So it was the most frequently used site. But we also noticed that among female sex workers, Twitter usage was very high. And this was mainly because they used Twitter to find their clients. Again, the reasons for using cell phone, reasons given for using cell phones were to make new friends, to stay up to date with family and friends, share experiences and opinions and views, and also for entertainment. But if you notice, for female sex workers, there was a high usage for business purposes and also for casual sex partners. We also posed persons to find out their interest in receiving MSM and sex worker specific health information. and we found that most persons were willing to receive information and wanted to receive information, but they wanted to receive this information either in person or via text messages. So more hidden ways of receiving information and not necessarily on a broader social media platform. And again, this may have to do with the tolerance for MSM and sex worker activities in Jamaica. Frequency of viewing health information online. We found that most respondents reported infrequently or never viewing health information online. For all groups, health information was viewed daily, less than 10%. Female sex workers reported looking at health information online most frequently, which was monthly. Male sex workers reported infrequently or never looking for health information online. However, the remaining male sex workers reported looking at health information at least monthly, but never daily. So again, it's pretty consistent with what we know to be the health-seeking behavior of men and women. Women tend to seek health information or seek out access to healthcare, while men do not. And the MSM population and the male sex worker population were consistent with the male pattern of seeking health information. Persons were also very willing to share information on social media sites. Majority were willing to share because they thought it would interest or help others, and secondly because it was new. So they are looking for more innovative health information or health information that they may not have had access to before. So from this study, what Sea Change realized that it marks, we know that MSM and sex worker populations are hard to reach populations. Because of the stigma and the discrimination they tend to face, they don't access health information as readily. And this study provided important findings on how to reach them via social media channels. We also noticed that there was a high level of access to cell phones, with MSM being the highest, and there was a high level of internet access among MSM and male sex workers. Lower levels of internet access among female sex workers, and the internet was mainly used to access social media. Female sex workers had higher rates of using the internet for health information, and more trusted sources of health information included health professionals, family, and friends. So it is that an organization is going to develop health information content targeting these populations, then it needs to come from a trusted source. There was also high levels of interest in receiving group-specific information, so they preferred private channels, such as directly emailing or text messaging, and not necessarily broader social media platforms. Recommendations coming out of the study: communication strategies for reaching marks need to take into account their intended audience's level of technology access and preferences for using these technology. We also need to ensure that communication approaches using social and mobile phone-based media are multi-directional and do not rely too heavily on one way of communication. So you saw in the slides that we showed that while Facebook was a preferred social media platform, most female sex workers were also using Twitter and YouTube, and they were using these to find clients. So if you are targeting a specific population, then Facebook only would not work. You do need to use more than one channel. You also need to involve individuals that are trusted by marks, such as health professionals. because the information coming from these individuals lend credibility to your message or your program. You also need to consider the appropriateness and limitations of using social media as a communication channel when developing your programs and strategies. Ensure the privacy and confidentiality of your audience is taken into consideration, and also ensure precautions to ensure their personal information is not compromised. One of the lessons we learned from the sex workers is that most of their families don't know what they do for a living. So they don't want you to give them printed material because someone may see it. They do prefer that you text them directly or that you send them an email where they're the only ones that may have access to that information. Innovative and creative means need to be employed to disseminate HIV and health information and engage populations that are hard to reach in dialogue and strategies towards their own protection. Because as we pointed out in the bar chart, MSM do not access health information readily. So there needs to be creative ways to engage the population and to interest them in taking care of themselves. Their health-seeking behavior is quite poor. And that is my presentation. Thank you.
All right, thank you, Anya. That was a really, really excellent presentation, and I think it gave us a lot of, probably further questions. I'm going to ask that everybody hold their questions for now, make a note of them so that we can get back to it in the question and answer phase of the session. But right now, we're going to go in straight to our next presenter, Ms. Muturi, and I'm just going to put her slide back on the screen, and we should be able to hear from her now. Please try your mic, Ms. Muturi.
Can you hear me now? Good. Okay. All right. So again, my name is Nancy Muturi, and I teach at Kansas State University. I'm in health communication, and I'm excited to be part of this webinar. Next slide. Okay. For some reason I don't. So today we will be quickly talking about defining what eHealth is all about. A little bit about mHealth, which is now current, one of the terms that are commonly used today. We want to talk a little bit on gender and health issues in the Caribbean, particularly in relation to ICTs. And from there, we talk a little bit about what we need to consider when we talk about women and eHealth. Next slide. So how do we define eHealth? This is a common definition that has been, you'll find it in almost every document, every research that focuses on health communication and eHealth. And basically, it's a combination of or utilization of information communication technologies to really transmit and store and retrieve some kind of digital data for clinical and educational purposes. Next slide. So when we talk about ICTs, there are many kind of gadgets and devices that are being used in terms of communication technologies. I use one of the definitions of UNDP. They refer to ICTs as innovations in microelectronics computing. That includes hardware and software, use for telecommunications and microprocessing, and also use of semiconductors and fiber optics. In other words, This is all about telecommunications, how we use broadcast media, information management systems, audio processing, transmissions, and anything that's networked. You can use a combination of one or more devices when you refer to ICT use. Next slide. So ICT and eHealth have been, or rather, use of information technology has been globally recognized. Healthy People 2020, for example, does emphasize the use of ICTs, information technology, to improve population health, and that does not mean just in the U.S. or in the more developed world, but also in the less developed countries. The Millennium Development Goals also has underscored the benefits of using ICTs or information communication technologies in achieving not only gender equity and health and equality, but also in health, improving people's health. Next slide. So when we use ICTs for health communication or health information, that's where we now refer them to health information technologies or HITS. Although this term doesn't always appear, but basically that's what it's all about. So really using these communication technologies for health purposes. And this has tremendous promise in terms of delivering not only the healthcare, but also health promotion and also behavior change, whether in developed or less developed countries. So use of communication technologies or ICTs has been, it has a lot of benefits, and I'm sure if you look at most of the websites or other information or research, you see a list of them. Almost everybody talks about what are the benefits for it. And this is just kind of a summary of what has been addressed. And maybe this is not all. I'm sure I'm missing a whole lot more. But in terms of healthcare services, diagnosis and treatment, that has been there. It has been emphasized. Health surveillance in terms of research, and that has been there and has been established. Healthcare policy and decision making. So technology have played a major role and has actually been addressed in some of the healthcare policies and also IT policies. In terms of health literature, there's plenty of literature now that has come up in terms of using ICTs in health and healthcare. Healthcare marketing, we see more and more organizations really using communication technology to promote healthcare services, healthcare information, healthcare research, and everything else. Then in health education, knowledge, and also research, there's plenty of that being now used in terms of ICTs and HITS. So health communication, again, ICTs are right in the middle of health communication. So in regard to the Caribbean, mostly the Caribbean, there's plenty of ICT use in the region, particularly for surveillance. I think the first presenter just talked about research and the use of communication technology. That's a perfect example of what ICTs have been used for. But at the same time, they're also being used for medical surveillance. So they have also been extensively used in managing information systems, particularly in patient information systems. So that has been established over the recent years, and many more organizations and healthcare organizations are particularly moving towards that direction. Information dissemination has been there. Websites are everywhere. Almost every organization, regardless of the size or the resources, they've actually established a website but that is mainly for information dissemination. However, there's not a whole lot in terms of communication and behavior change, because in health communication we talk about information dissemination does not lead to that is not communication. It's really disseminating public information. So there is that need for behavior change, and there's that need for really communicating with the public. That is the direction that that is now being proposed. What that means is there's a need for more interaction with the audience. How can we use these communication technologies for organizations to interact with the audience that they are trying to target? And on the other hand, there's very limited audience participation. Besides the Facebook and the social networks, there's a lot more needed in terms of the credible organizations, for instance, the Ministries of Health and other government organizations or even non-profit organizations, to be able to give the people the opportunity to interact with the organizations, with other people in regards to the health messages and sharing the information. Next slide. So these are just examples of how eHealth applications have been applied. For example, I just mentioned websites, but also in regards to emails, message boards, chat rooms, that is also being used widely, and probably not so much in the Caribbean region, but it has been there in many other more developed countries. Online support group systems and networks and communities, that is kind of the in thing now, particularly in the more developed nations, because they have the capability and the systems to make that happen. And what that means is people can share their stories, they can network, they can support each other. And especially, you know, sometimes people are suffering from illnesses that possibly all they need is really to be coping with it. And that kind of social support helps, and interacting with other people in the network, it helps with the coping of with some of those illnesses. So the electronic health records that has been now established, health decision support systems, tailored health education programs, healthcare websites and portals. I think all these are common, and we've seen them everywhere. Online gaming is now becoming a big thing, where it's not only entertaining to the people, but also it does provide the information and interaction that has been lacking in terms of health communication and health promotion. So the gaming by itself kind of puts the people, gives them the opportunity to interact with the message through the communication technologies. Next slide. So if used correctly, ICTs or HITS, they do have a huge potential in terms of increasing provider and also the patients access to relevant health information. So it is very important for them to have that access, because once the patient is at least have the information, then they are able to ask the right questions. They are able to at least interact and be able to inform about some of the issues that they're dealing with. If I could just throw in an example, some of the patients do not take the medication properly, or they do not adhere to what the doctors order, because they are not clearly aware, they're not knowledgeable about what they're dealing with. And that kind of interaction, if they can go online and seek more information, communicate directly with the doctor, then that way they have a better understanding. In terms of HITS or ICTs also enhance quality of care. They do reduce healthcare errors, and I think anybody can give examples of some of those errors where doctors make errors, patients make errors, and those can be eliminated through use of ICTs, because you can go online, you can talk to the other person in terms of discussing issues that you're facing. Other examples include the doctor-patient interactions. Sometimes you don't even need to go to the doctor. You can interact through the website or through other communication technologies. Patients get empowered, so they are not just there with the doctors to listen, but also they are there to participate in decision-making. And at the same time, it does encourage them to make or at least adopt health behaviors. So how do we define eHealth? This is again one of the concepts that has been promoted. And this is mainly because of the advance in use of cell phones and medical and the medical technologies is now becoming more mobile. So, and what this means is people can actually use a wireless connection server, a personal server, which could be a personal computer, a cell phone, anything that you own in terms of the communication device, and really connect to the medical or to the medical server. So that's what eHealth is all about. So however you use it, you're really communicating, you're getting in touch, you're accessing information, and it could be at the personal level and also at the organizational level. So if a doctor is in the somewhere in the rural communities, they can actually connect to the main server at the hospital to be able to access the patient records. And so basically this has been kind of the direction that in terms of telecommunication that the medical field is going. So this development is being driven again due to the mass markets for cell phones and also other portable computing devices. And possibly in the next few years, this is possibly where the eHealth will be headed. Next slide. So in terms of the Caribbean, there is again a whole lot of potential. I pulled out some of the data from the documented surveys, and so in the Caribbean generally, medical technology is expanding and rapidly. Again, due to the penetration of only the web, the internet, but also the mobile telephones. So there is, especially in Jamaica, for example, mobile penetration has more than 100%. There are people who have more than one cell phone. And that's a good thing in terms of eHealth, although internet is still dragging, particularly access to internet at home. But when you look at the other, in terms of portable and other cell phone technologies, then that is a good opportunity for at least for eHealth in the next few years. So these are just other examples that I pulled from one of the documents of, and again, it's not every country that has this kind of data or current data. So these are just examples of what has been documented. Every country has it, but some of it is a little bit outdated. But this gives you a little bit of examples of what you're talking about in terms of penetration. If you look, for example, in Barbados, access to internet at home is almost 70%. Suriname is a little bit, computer penetration is not a little as high. So, and this is basically what you're referring to, that we have the access, but mostly, although not so much for internet, there's quite a bit in terms of mobile and internet. Yes. So in terms of digital technology, there are some divide issues that we do need to talk about and communicate about when we're addressing eHealth, and that includes things like age. We are dealing with an age that is more high-tech. They have access to all kinds of gadgets. They are educated, but it's not everybody who is at that level. So those kind of gender and age differences need to be taken into consideration. Other issues in terms of income. Although everybody has a cell phone, it's not everybody who has a smartphone. And those are issues that has to do with how much they can afford, and in terms of credit and bills and costs. And these are things that we do need to talk about. Issues of disability access. When you're using computers, for example, is it everybody who can access and who has who can read, because we have people who have disabilities. How do we need to incorporate that? So that issue of access, for example, organizations need to be considerate about that. Then there is issues of literacy and low literacy. My research, especially in Jamaica, shows that although people are very literate, when it comes to computer technology, it's not everybody who is at that level, and that needs to be considered as well. And then there is obviously the geographical region. Although we do have internet access, the connectivity in some of the regions might not be as good as other regions. And those are, again, issues that to be taken into consideration. Next slide. So ICT usage in the Caribbean, and you can see they've really tried in so many other areas. However, I highlighted health there because there's still very limited usage of ICTs in eHealth. And that is, again, why we want to emphasize a lot more on what can be used. So when we come to gender and health, this is very important because we do have many issues. As the first presenter touched a little bit, there are some gender differences in terms of access and use of communication technologies. Women in the region are more likely to suffer health issues, again, in terms of, for example, HIV, AIDS, diabetes, and many other lifestyle diseases. Research has shown that more women do have issues with HIV and AIDS, particularly due to gender and inequality, so they're more likely to be infected. Women are also less likely to have access to preventive health care. And again, this comes back to income, access to insurance, and also because of stigma and discrimination. Next slide. So based on that little background on health and women, there's also the issue that ICT, when we use them, they are not also gender neutral. So they do have their differences in terms of how we use and access ICTs in regards to gender and communication. So previous studies have shown that women are more likely to search for health information. This was emphasized earlier. Women are more likely to use the ICT for social networking. This was also pointed out earlier. There are also women who are living in less developed countries, although they are less likely to own a cell phone. When they do have one, then they are more likely to use it mostly to connect with the healthcare and also to feel more empowered. And that's basically why it is actually important to emphasize on use of these ICTs when they have access to the cell phones. So when they do have access to ICTs or communication technologies, most of them, they do have access, especially the internet access at home, and that the reason is because they not at home but at work, and they do not have a whole lot at home. And however, even at work, it's also limited because of the kind of work that they are doing. I think if you and some of you probably are aware of that, call centers, for example, they have lots of women working there. In the offices, most of them are working as typists, word processors, data entry clerks. That does not enable them to really have a real knowledge about IT use. Sometimes even the internet access might be limited. So women also do have limited IT training because one thing when I did my research in Jamaica, for example, results show that there are actually more women who are in the doing IT courses as opposed to women. So women are not very computer literate, and that also affects the way they use ICTs for health purposes. So specifically, some of the gender considerations that we need to be considerate about include the gender policies, the components in the IT policy that has to be addressed and incorporated. Then there is the issue of ownership. Who really owns the hardware or the software? Because if somebody owns it, how much can a woman use it, and to what extent can they share or at least or even have access to the information that they need? Training and capacity building, access points. Do they have access? Is it at the private sector or public sector? Do they go to the public library? So those kind of issues. Then there's cost and capability. How much can they pay for it? If it's a phone they're using, how much data can they download? All those are issues that to be considerate about. And then we talked about computer literacy, and there's research that shows that there are a whole lot of women who suffer from technophobia. They see that as too daunting for them. The issue of participation, that has to do with how much a woman can share, participate in the healthcare communication. There are lots of issues in eHealth when it comes to privacy and confidentiality, especially when you're suffering from some of the stigmatized illnesses or diseases. For example, when you have somebody with HIV, that's obviously a stigmatized disease. How do you really share that information online or with other people? And that has been an issue with eHealth. Then there's ethical issues in healthcare. The extent to which a woman can be really confident that whatever they share with a medical doctor or healthcare person is not going to be shared with other people. And there's those kind of issues that might be of worry to a lot of people who might want to use them. Then there are obviously security issues in regard to IT access. Where do you share, if you use your cell phone and you share some information and somebody discovers that you have HIV/AIDS? Are you really secure? Are you really safe? Or is it likely that you might be abused because of that kind of information? So a few things to consider, and I think this is the last slide. When you're using eHealth in terms of communicating about women and health, there are issues that to consider when it comes to really asking questions like, can they really understand how to use the communication technologies? So regardless of the device, whenever we use it, keeping that in mind. How comfortable do these communication technologies fit within the policies and practices? So that is very important, because it's not just disseminating information and asking people to use them, but looking at how do they fit overall. How affordable can they be? And again, in terms of cost and capability, that is important. The messages delivered through health, is it enough for them to understand? And again, some of the information disseminated might be too technical. So really making that information easy enough for the women on the other side to be able to really understand it. And that has to do with the language used and also the terminologies used. That has to be easy enough for people to understand it. Again, really being able to consider issues of adaptivity, how much they can interact, and also considering that are these devices self-correcting? If I make an error, can I go back and erase it? Can I change that? Or is that information going to go out the way it is? And I think each one of us has had issues, regardless of what level of education, where you put in something online and you want to pull it back, but you're unable to do that. In terms of eHealth, that's a more serious issue that needs to be addressed. Then finally, the information that's going there through the ICTs, it needs to be really interesting to the people that you're targeting. In this case, if you're targeting women, can they see this information as relevant to them? Can it be engaging to them in terms of, so that they can engage and participate in the process? And so those are some of the considerations that we do need to take care of. And I believe that's our last slide. Thank you very much. Those are my resources, some of them.
Thank you so much, Ms. Muturi. That was incredibly comprehensive, a very comprehensive presentation. You covered everything from the basics of public e-health and straight down to looking at a specific population, that is women. And I saw a lot of overlap with your key questions, that's Anya's key questions, about making sure that the target population uses the technology, is able to use technologies, interested to use the technologies that we want to use for intervention. So that's very interesting. At this point, I just want us to go ahead with the third and final presentation. If you have any questions, please make a note of them, and then after the last presentation, we will probably open up the mic. We will open up the mic after the presentations, and you'll be able to voice your questions. So I'm going to go ahead and allow Dr. Forbes to make her presentation. Thank you.
Yes, okay, I think everybody is hearing me now. Yes? Thank you, PAHO and eSAC, for inviting me to participate in this webinar. And a warm hello from sunny Jamaica to all who have joined us online. My focus is on public health in relation to ICTs, in particular as this relates to the creation and consumption of media contents. Nancy, you did a fantastic job in terms of laying out the foundation for what I'm going to build on, ICT penetration levels and key questions. Those relate to what I'm going to say as well. So if I don't say some of what Nancy has said, it's because she has already said it so well. So let's move forward. My slide. Okay, public health and information communication technologies, or ICTs. What made me decide to do research into ICT-related areas? Well, really, I'm a businesswoman, and I'm co-owner of a 30-odd-year-old multimedia television production company. So media is in my blood. I'm interested in all aspects of media, and that's what led me to explore the influence of television on adolescent sexuality. It was something that everybody was talking about in the late 1990s, early 2000s, but nobody was really studying that area. And so coming out of all of that concern, I explored the influence of television on adolescent sexuality over the period of 2004 to 2010. It became clear to me that Jamaican youth were beginning to build an affinity to new media like mobile phones and the internet. They were not technophobes. They were not afraid of technology at all. From as far back as 2004, that's 10 years ago, teens were watching videos on the internet as well as via mobile phones, popularly called cell phones in Jamaica. So when you hear me say cell or cell phone, I'm talking about the mobile phone. But our youth in Jamaica were using their cells and the net for far, far more than just watching videos. Many of them were watching pornography online, even via the computers at schools, computers provided through our e-learning project by the government of Jamaica. In fact, in that youth and television project, I learned of pay-per-view to see porn via cell phones. Jamaicans are ingenious, and hustling to make a buck is a part of our everyday reality. So it really wasn't surprising to me that school children with cell phones were charging other school children without this technology to engage in watching pornography that was recorded and kept on their mobile phones. In schoolyards, teens huddled to watch the riveting content via tiny phone screens. The book, which evolved out of that research project, Music, Media, and Adolescent Sexuality in Jamaica, was published in 2010. In it, the close nexus between watching dance hall music videos and sexual activities were highlighted, with 70% of all adolescents who had ever had sex reporting that they watched dance hall videos most of the time. Coming out of that body of work, the importance of media literacy in schools as one way forward, as to family life education designed to help adolescents to understand and to value themselves, were highlighted in that book. While the focus of this book was on television, what some call old or traditional media, many persons do not actually include television in their definition of information communication technologies. But I always have, and I'm happy to hear that Nancy, and to see in her slide that Nancy included broadcast media as ICT. because it is. Anyway, youth in Jamaica were beginning to transition from old to new media for interactive engagement as well as for content consumption. Watching the latest and especially the uncut versions of music videos online, the internet, that was where the action really was. So coming out of the findings from that first book, I was drawn to explore how youth were engaging with new media. So I pretty much jumped right into what I saw as a natural follow-up, an exploration of how youth were living their lives online. In working towards the follow-up book, my work therefore moved from a focus on the old media of television to new media, the internet, and cell phones, especially as it relates to social media. And you see, social media, we have hundreds of social media sites available nowadays. Now, here are some of the questions I sought to answer in exploring the Youth Online project. What do the cell phones and the internet mean to youth in Jamaica? How are they using these technologies in their lives? Are Jamaican young people different from those in selected countries in terms of their relationships with technologies? And for that project, two key definitions: youth related to those in the 17 to 30 years age range, and online for this study referred to the internet as well as the mobile phones, because growing up in Jamaica, when you're on the line, it was in those days, it was the phone that we're talking about, in those days, the landline. And so for me, online, now mobile phone as online is a natural fit. Additionally, a lot of Jamaicans go online via their mobile phones, even when it is not a smartphone. So going through the research design and methodology. Well aware that I was trying to catch a moving target, and that the research study would merely capture a moment in time, given the rapidly changing nature of the technologies under review, the core of the research design was to hear directly from youth, to focus on their views and opinions, to listen to them via Twitter, something called social listening, and even to watch them at Twitter. A multimodal research design consisting of qualitative and quantitative data gathering tools and methods was chosen. Samples were purposefully and practically selected based on the need to include a variety of voices at various geographical and social levels, locally and overseas. You're looking at the slide and you'll see that there are actually two different surveys, two different samples. The Youth Online survey as well as the Twitter survey. For the qualitative aspect, you see there that focused on Jamaica using a variety of methods, including what an interesting approach called digital ethnography. I pretty much lived on Twitter as a participant observer for about 1 year during data collection. Over that period, and Twitter was brand new to me. I didn't use Facebook because I couldn't get a handle on Facebook. It was overwhelming for me, and researchers have to work with the technologies that will work with for them. As well as on Twitter, there was a very engaging set of Jamaicans who were using technology, that technology in particular, more than many others, and they were blogging and promoting their blogs on Twitter. And so Twitter really opened my eyes in many ways to areas of use of technologies, ICTs, that I wouldn't otherwise have encountered. Over that period of Twitter, I engaged in crowdsourcing information and soliciting feedback on a variety of issues, as well as the Twitter parties that we call tweet-up I mentioned earlier. Importantly, I want to stress that I'm making no claim to having a representative set of samples, or that the findings can be generalized beyond those who participated in the project. Clearly, however, I did tap into some important views that were widely shared among youth. Additionally, based on secondary data, it was clear that Jamaican youth overall were not entirely peculiar, and in fact, a number of findings coming out of Pew Research in the United States show how closely some of our youth reflect the findings there. So, looking at some of the findings, social media and the psychosocial health of youth. The important point is that youth are not all alike, even though I made the point that there are commonalities, but especially in Jamaica, social class, gender, Nancy mentioned gender differences between boys and girls, males, females, color, race, and class in Jamaica are important variables. Access to different types of technologies, such as smartphones versus feature phones. This makes a huge difference as to how young persons engage online, the kinds of content they consume, the way in which they engage on social networks. As to internet access, whether in public spaces as internet cafes versus at home, these contribute to nuanced and multi-layered nature of youth relationships with social media. That's an important point to bear in mind. The ways in this kind of access you have will help to dictate how you relate. Now, I'm going to look at the cell phone. Just a quick overview. What does a cell phone mean to you? For Jamaicans, you see I do a comparison there because I had looked a little bit at, it was college students in the United States of America. In Trinidad, it was workers, mainly at hotels, and in Dominica, it was more community people in general. And so we see in Jamaica the positive responses, not that Jamaicans are Pollyannas, some will argue they might be, but to Jamaicans in general, the cell phone is very positively viewed. And the comment, "it means a lot to me," was one of the most frequently occurring responses. Whether this was from an uptowner or a downtowner, as we refer to the social differences in Jamaica, or from country or town, responses were similar. It means a lot to me. Cell phones were seen by youth as pretty much an extension of their arm. They lived for their cell phones. Aspects of self and social identities were intricately enmeshed in the owner's phone. How it looked, what model it was, what it could do. And in fact, some of the teens felt that if they lost their cell phone, that they would die. Now, school policies pertaining to access to cell phones during school time clearly need to be reviewed, especially now in Jamaica, in the context of tablets in school program that we hear is to come on stream in very short order. Moving specifically now from the cell phone to the internet, the data were disaggregated so as to get a better grasp of how poor youth felt about the internet, including access or lack of access issues. The views of 108 youth from inner city schools were examined. We see here what the internet means to me, and you can see the gender differences. Remember, these are all inner city young persons. This was an open-ended question, so it wasn't that they were presented with any specific points. They were asked to write in what the internet meant to them, and the responses were analyzed and categorized. And as we can see, using the internet for schoolwork featured heavily for girls, almost 70%. Now, boys learned differently and used the internet for general information and for educating themselves. Interestingly, though, responses that were categorized as using the internet for entertainment did not draw as large a response percentage-wise as I had anticipated. If you look at the emotional support, even though perhaps I shouldn't have been surprised because this was reflected in the first earlier study I mentioned, which looked at television and adolescence and the ways in which television offers emotional support. But it surprised me that a full 30% of girls were looking to the internet for emotional support. This is less than half of that percentage for boys. Now, The girls, I pulled out a couple of the views of the inner city girls and what I call their love affair with the internet. We can see the kinds of things they said. The net is a new world for me that allows me to escape my problems and just talk and hang with friends. So the business of the digital divide, that's a real issue, because in talking to the inner city and the rural youth, they actually lobbied for internet access as a basic human right. To them, they were being deprived of something that would make their lives infinitely better. Without internet access, they felt that they didn't count. They weren't important. Their self-esteem really suffered. For them, being on Facebook was critical to their sense of self-worth. Can I just check if everybody is hearing me at this point? Despite this inadequate access, yes, good. Despite this inadequate access, youth found ingenious strategies such as sharing Facebook accounts. When asked to list their top 3 online activities, I was amazed at the extent to which Facebook dominated. So even those who were lobbying for access, internet access, as a basic human right, most of them were really lobbying for a way to get onto Facebook. Guidance counselors, we had about 11 of them in the project, pointed to many issues with teens on Facebook. These included regular quarrels that emanated from Facebook posts but moved into school life. Of course, we also had parents, guidance counselors talking about parents who complained about the quantities of hours that young people were spending on Facebook. To my surprise, both boys and girls corroborated and elaborated on what the guidance counselors had to say as to how Facebook impacted their lives. They didn't disagree with the guidance counselors at all. They really showed that they were correct in what they were saying. Some of the impacts on the young people's lives were very positive, like operating businesses online and linking each other about schoolwork on Facebook. But many of us already know the negatives that I would have encountered, the privacy issues, the safety issues, and many, many more. These were discussed at length in focus group sessions. So last year when Pew Research came out with their findings that teens were leaving Facebook in America because they couldn't cope with the drama, as they termed it, I really smiled, because that was exactly the word that the Jamaican young people had used in our many discussions, that there was so much drama on Facebook. So I've talked in passing about the kinds of ways in which the young people feel that they're missing out and they're not important when they don't have access to the internet, and especially to Facebook. In fact, many teens, talking about Facebook now, see the computer screen as a protective shield, and they'll do and say things that they would not do and say in real life conversations or in real life face-to-face encounters, because the computer screen actually gives them a sense of empowerment, a sense of freedom, especially sexual freedom. And this is a quote from one of them. Quote, some girls probably feel more confident online because, you know, they're not seeing the person face to face, so they can say what they want. If we look at the age profile, and this is taken from socialbakers.com, the age profile of Jamaicans on Facebook. This is 2013, but it hasn't changed a great deal. The numbers are increasing. About 25% of the population of Jamaica is now on Facebook. But if you look at the age profile, the 13 to 15 and up to 24 years of age, 18 to 24, if you take those bands together, 13 to 15, 16 to 17, and 18 to 24, you'll see that it is quite a bit of over 50% of Jamaicans who are on Facebook are 25 years and under. When you compare that to other countries, you'll see that the Jamaicans on Facebook are quite young. And so the types of issues that were highlighted by the research participants are really issues of adolescence, where we have a search for self-identity, social identity, sexual identity. That's normal, that's expected. The challenge for us in Jamaica is our country's continued fixed gaze on sex and sexuality. And this was manifested in participants' discussions pertaining to Facebook. So some of the findings regarding sex and sexuality online really reflect features of Jamaican society offline. Manifestations of life online are picking up on long-established cultural practices. In fact, in the book that emanated from this body of work, I talk about Louise Bennett and a poem she did in the 1960s called Cuss Cuss, where, women were well schooled in the art of cursing. And we see that young persons have taken that online. I look at it in terms of that section I talk about from video like to Facebook. That's how I refer to it, meaning that young people who eagerly perform for the video camera, engaging in all kinds of highly sexual behaviors, have now moved those similar behaviors online to Facebook, Twitter, Skype, and their cell phones. In this book, this is a book that came out of the body of work. I didn't plan it, but an entire chapter is devoted to Facebook and young persons. And in this book, I captioned one of the sections, Facebook Face-Offs by Females. This is based on the number of stories that boys and girls had to shared in terms of how Jamaican teenage girls behave on Facebook. Again, on Facebook and in the across the wider internet, there's a tremendous amount of virtual sex that takes place online among males and females, as well as among homosexuals. And I was interested in the statistics that Anya shared with us, because I see that on Twitter quite regularly, the extent to which there's a great coming out on Twitter. It said that the female sex workers use Twitter for soliciting clients, and I have seen some of that. But especially over 2013, Twitter was like a great coming out party, because so many male homosexuals were coming out on Twitter. So in going forward, youth really need to be more roundly educated about how to use technologies like the mobile phone and the internet for productive purposes, such as e-work and micro work, so that they can earn a living, because the future of work is truly online, especially in a country like Jamaica, where youth unemployment levels are extremely high, in the approximately 40%. We know that ICTs can help. It is a public health issue when so many of our young persons in the productive phases of their life are either underemployed or totally unemployed. But there is hope. And we're beginning to see this happening, where DigiJam, which is sponsored by the World Bank in tandem with the IDB and the government of Jamaica, we've just had the third iteration of that conference, which runs over 2 days. Last year, the focus was on micro work and getting work online, mainly from overseas entities and via websites like eLands. This year, the focus was on creating mobile apps, mobile applications, and it's extended not just, it wasn't just for Jamaican youth, but for youth across the region, with a number of young people coming in from a number of other Caribbean territories. Now, thousands of youth have participated in these DigiJam conferences, and the gender balance is something that has struck me, because almost equal number of males and females were there on the weekend pitching their products. So we really need to put hands and heart together to help our youth to see a better way and a brighter future through the youth use of ICTs. But while doing this, we need not to diminish the value of some amount of cyber slacking that we need to allow online, because it really is a way of helping us to understand the technologies and the ever-changing ways of navigating our life online. And with that said, I thank you very much for listening, and I'm open to questions. Thank you.
Thank you so much, Dr. Forbes. Those three presentations were very, very relevant. We went from Anya discussing men who have sex with men and sex workers in Jamaica and their use of social media based on the high prevalence of HIV and low health-seeking behavior. We looked at definitions of eHealth and mHealth and gender bias in terms of using technology for public health. And Dr. Forbes just gave us a very detailed look at youth use of some of these technologies like social media. So I just want to open up the floor now to anybody who has any questions. You can raise your hand using the icon below the participants box. The icon is of a little raised hand. If you press it like that, it will come up. If you have any questions, just click that button and let me know. We'll open up the floor at this time to let you speak. Okay, go ahead, Dr. Faber.
First of all, I would like to thank to the three presenters for really very good information. For me, it was a special opportunity to open the window to a real region that I didn't know too much, and now I am really very clear about the relevance of the ICTs in many of those countries, and I like very much the way you approach the subject. So thank you so much for that. And I have one question, because I saw that you really defined the difference of gender, how gender is in some way telling us the way that people is using the ICT. I would like, and also the age, but I would like very much to know, what do you think about the possibility or the potential that the ICT has as a resource for aging population, in the sense that we, in all the countries, I think also in the Caribbean region, we are walking ahead to a very relevant presence of this range of age that are older than 60s. And I know that the literacy there is a little problematic. So what we can do to let people that really are vulnerable, because they need some support in their vulnerable situation, health situation, how we can do more accessible, because I didn't hear too much about how all the people today could be using this so important resource, and especially because people need to be supported emotionally, physical, and coaching their health condition. I would like something like that to know from you, any of you.
Okay, Dr. Ms. Muturi, would you like to answer that question, or if another presenter?
I can try and answer that. So your question is how do we really deal with the aging population, especially in the Caribbean and Latin American region? I think one of the points I raised is really the differences, the age differences in terms of how technology has been used. And as Dr. Forbes and the other presenter kind of mentioned a little bit or discussed, the new generation is very comfortable with the use of technology. However, that is one of the biggest issues that is facing the region at the moment, because although we are moving towards using the mHealth and using the mobile technology, those are gaps and that have not really been addressed adequately. One of the things that needs to be done, at least, is through capacity building and training, especially for the older generation. I remember some of the organizations when they started talking about eHealth and ICTs, they did have training sessions. Women's Media Watch in Jamaica, for example, they had training sessions for women who are a little bit older, because that was a group that was in the organization, on how to use computers. So training sessions went on. There are examples, for example, in Latin America, in Peru, for example, the organizations that have been documented to do the training for the women, but that was during when the computers were starting to be used. I think now that needs to be, more resources need to be put in the training and capacity building, particularly among women who do not have a whole lot of training, or they are not even technologically savvy when it comes to even using those the mobile devices that we talked about earlier. So when we are using, for example, even Facebook, going online, really teaching and talking to, and look at Dr. Forbes, one of the graphs there, you could see there's an elderly population. It's not as many who are actually on Facebook, but how can we really train them and encourage them to be part of it? So that is the kind of approach that needs to be done when it comes to training them to be able to access, to be able to interact, to be able to empower them. So capacity building, that's where the resources need to be put a little bit more. And that means organizations, whether it's non-profit, government organizations, when they're considering eHealth, then they should have a component for training, especially targeting that particular age group.
Thank you, Ms. Muturi. I think we have another question, and you can also put your questions in the chat section if you prefer to put it there. I'm going to go ahead to another question. D. Novio.
Thank you, Soraya. This is David, but I changed the device, so I am connected through the computer directly. Thank you so much, all of you, for the excellent presentation, and I have a question for you. As an expert on this topic on communication, I would like to ask you about what do you think about a recommendation for us, an international institution on public health on eHealth? What do you think that which is the focus in which we have to work on eHealth, social media, telemedicine, from your perspective? Thank you.
Dr. Forbes, would you like to take that question?
So Euro, sorry, I didn't follow everything that was being asked.
Okay, Dino Vio asked, as an international institution, the Pan American Health Organization, what direction do you think they should take in terms of public e-health? What should they focus on? Social media, telemedicine? The question is also open to Anya and Ms. Muturi as well.
Yes, thank you very much. I think what they should focus on will depend on the different age groups and the different, the male or female, because, for example, in Jamaica, Facebook in Jamaica, 53% of their accounts are females, 49% males. And so it really comes down to targeting based on the profile of who you're targeting. Pew Research has identified in the USA that the fastest growing group of Facebook account creators are the more, the elderly. And so that is something important for older persons now to keep in touch with their families, grandchildren overseas. And so it would have to be a very strategic decision, but social media should never be excluded, because even in Jamaica, where household internet penetration levels are so low, like 15% 13.3%. You hear the young people talk and they find a way outside of the household to get online. And so it would have to be based on segmentation.
Thank you. Ms. Muturi?
I think for an organization like PAHO, I think that one of the biggest thing that I think they should be focusing on is really documenting some of their success stories, because right now, and I don't know if I mentioned this, there's not a whole lot to learn from. For example, if you want to implement a program somewhere in Peru or somewhere in Brazil, for example, you need to be able to see what has worked elsewhere, given the resources that are there. They might not have adequate resources, but that kind of documenting, it is lacking. And the other thing is really keeping up with the research. Social media, digital technology, everything is moving quickly. So organizations like this one needs to be moving as quickly as possible to catch up with the technology. And because most of the smaller organizations are learning from PAHO, WHO, CDC, all these major organizations, then they should be making the trend, which means in terms of research, really getting to know what is going on. And you're not doing research only from the organization's perspective, but really going down on the ground level to see what are the people using, what are they familiar with, do they have access to. And again, having access to technology doesn't mean they always know how to use them properly. But we do need to have that kind of information. So anybody else who wants to really do anything with the eHealth or mHealth or any kind of digital use, then they need to have that kind of resource to rely on or to fall back to. So PAHO needs to support research, they need to document, they need to put on more resources in terms of training, and at the same time they need to be engaging people at different levels. Well, and it's easy to do that because they can engage universities, they can engage researchers, they can engage non-profit organizations. That kind of facilitating that kind of dialogue is important.
Thank you. I had a question for Anya. One of the slides spoke to the interest of sex workers and men who have sex with men in Jamaica. They had specific interest in receiving health information through the various ICT channels. Very high interest, 83% and 93%. Has anything come out of that research in terms of, was the data used to inform policy funding, new projects that would be able to target these populations through ICT, Anya?
Yes.
Well, in terms of...
No, I promise to God, I'm so terrible.
So, what Sea Change did was we did not do the actual programming. So we gave the data to organizations that were working with the specific groups to develop the programs. And the Ministry of Health National HIV Program, they were working with NGOs to develop specific materials for MSM and sex workers. The Ministry of Health also uses text messaging to inform female sex workers of the empowerment workshops that they now have for female sex workers. And with JFlag in particular, they have been using the internet platforms and social media platforms, particularly sites that target MSM, to present HIV prevention materials. As far as I know.
Thank you, Anya. And before Dr. Forbes leaves the session, we just want to say thank you so much to her and to all the presenters for really excellent presentations this morning. I think we got a lot of really pertinent information about specifics in the Caribbean. And Nancy spoke about success stories, and I think that this morning we were able to make a start in terms of highlighting some of the research that's happening in the region. Please remember that next week, Tuesday, at the same time at 10 Washington, D.C. time, we will actually look even further at specific projects dealing with public e-health in the Caribbean. We'll be highlighting 2 projects in particular. So thank you to everyone for attending. Thank you to the Pan American Health Organization for bringing greetings and for their support of the project, in addition to University of Toronto and the IDRC. And we welcome you again for next week's session. Thank you.